Hi, everybody. Welcome to the AVF Podcast. The Asia Ventilation Forum is a group that is not for profit. We come from different Asian countries and we travel physically to different parts of Asia previously, but now mostly we do things virtually to share our experience in respiratory care and intensive care to colleagues in the region. The idea is to, hopefully with our sharing, improve the experience of healthcare workers across the region, but importantly to improve the outcomes of the critically ill in the region as well. So this is the AVF Podcast, Asia Ventilation Forum's short form is AVF, and we have just started two different series. The first series is titled ICU Tips and Tricks, in which we will interview experts on different clinical scenarios and ask them how they would respond to each of them. And the second podcast series is this particular one, which we will call the AVF Podcast, Behind the Scenes ICU Stories. My name is Jason Phua. I'm a respiratory physician and intensivist from Singapore. And today, we are really honored and glad to have Dr. Jigi Divatia with us. Dr. Divatia is a professor and head of the Department of Anaesthesia and Critical Care and Pain at Tata Memorial Hospital in Mumbai in India. He was past president of the Indian Society of Critical Care Medicine, as well as past editor-in-chief of the Indian Journal of Anaesthesia. Today, he's also one of the board members of the Asia Ventilation Forum. And for today's first ever AVF podcast, Behind the Scenes ICU Stories, we're going to go behind the scenes to ask Dr. Divatia the question of how we, as in Dr. Divatia and his Indian colleagues and his Indian citizens, battered India's second COVID-19 wave. So I'll call you Jigi, Dr. Divatia. We have looked at the official statistics, right? Last checked on the WHO website that as of today, there have been 31 million cases of COVID-19, and that's an official figure in India. There have been 424,000 deaths in India since the start of the pandemic. But we also saw recent papers, as well as one from the Center for Global Development, which showed that even though the official death toll is 400,000, the modeling suggests that it's anywhere between 3.4 to 4.9 million deaths. Some of these were in the first wave, but many of these were in the so-called second wave, which is April to June of this year. And that accounted for 1.4 to 2.4 million deaths. So each of them is a real human tragedy. So I just wanted to start off by zooming into your ICU. Jigi, you practice in the Tata Memorial Hospital. How has the second wave affected your very own ICU?
So thank you, Jason. I think it's a great privilege and a pleasure to be with you at this AVF podcast. And unfortunately, we are talking about something which has really hit us very hard, the second wave of the COVID pandemic. India, as you know, has been particularly hard hit, and it's sort of made international headlines, and you've seen all these reports of so many deaths and so many cases. But having said that, I think, we had officially 400,000+ deaths, and there are estimates which have put the number of deaths 10 times higher. But then we also have to consider that the official figures are the officially positive cases and the deaths of the officially positive cases. And if you have more deaths projected from various data sources, there are also many more cases that have occurred which have not been recorded. So if we keep the percentage the same, I guess, whether it's a multiple of 10 or a multiple of 5, proportionately the proportion of deaths would be the same. But as you mentioned, every death is a human tragedy. And whether it's 40 deaths or 400,000 deaths or 4 million deaths, each is a tragedy. And of course, the more deaths, the greater and the manifold is the tragedy. So that's for sure. Now, our hospital is in Mumbai, and it's a cancer center. And we are also the sort of cancer center for the city for all cancer patients with COVID. So if any cancer patient in the city has COVID, they can be referred to our center. And so we look after all the cancer patients in the city of Mumbai, within the municipal limits of Mumbai. Now, I don't think it's a statement of fact, and there's nothing to say that we had a huge surge of cases, and we had lots of patients both in the hospital and in the ICU. But having said that, this time around during the second wave, we fared better. We had to open up more beds. We had to actually make a new ICU to accommodate patients, because being a cancer center, we are also keeping our cancer services running without restriction. So we had to accommodate our usual cancer care load plus the COVID load. So we had to expand capacity, especially in the second wave. In the first wave, we coped reasonably well because of the lockdown. We didn't have as many patients, and the COVID patients sort of filled up the ICUs and so on. But this time around, we were prepared. We had personal protective equipment. We sort of knew what to do. Our protocols were in place. Our staff were vaccinated. Our staff was pretty motivated. We didn't have as much absenteeism. We had people who were fairly well trained. So I think despite the huge load, in our hospital, we were able to cope reasonably well. So, and when we looked at our mortality in the first wave in the ICU versus mortality in the second wave, it was almost exactly the same. So of patients admitted to the ICU. So yes, there was a surge of patients, but at the same time, I think our preparedness was there, both mental preparedness as well as physical capacity and resources, and our knowledge. We have, of course, we are better equipped in terms of knowledge of how to treat patients and complications and so on. So overall, it was not as tense and it was not as nerve-wracking as it was in the first wave, although the physical load was higher. I mean, I'd put it that way.
So how about the rest of Mumbai? Was it, were the other ICUs equally prepared?
Yeah. So now Mumbai, I'm sure in the media there was a lot of talk about India, being gasping so many deaths and all those sorts of things. Mumbai did not have as big a problem of bed capacity and oxygen capacity and so on compared to certain areas of the country. I mean, when you talk of India, and it's been a bit patchy because some areas did well and some didn't do so well and some did pretty badly. So in Mumbai, I think what happened was the authorities, we had these big jumbo centers, which are essentially man-made structures which sort of came up during the first wave and to accommodate patients. And we did not close down those jumbo centers. And although many of the private hospitals and public hospitals started closing down COVID wards and COVID ICUs and reducing the number of COVID beds and doing the general sort of work that they would do, the jumbo centers did not close down. And when the wave hit, we were able to accommodate the patients in the jumbo centers while the hospitals opened up, again made more COVID beds available. And eventually the municipal corporation, the state government took over all the beds except 20% of the beds in private hospitals were all taken over for COVID purposes. So during the second wave, we had not completely shut down COVID centers, the jumbo centers. Those jumbo centers had ICU beds, so there was physical beds were available. So we didn't do so badly, at least in Mumbai, as far as the number of beds was concerned. We had a sort of central dashboard and a ward level dashboard. So, so they knew exactly how many beds were vacant, in which hospital they were vacant, and all admissions to hospital were triaged and centralized telephonically via this dashboard, which the municipal corporation of Mumbai maintained. And so it was difficult, but not impossible to find a bed. You could not get a bed in the hospital of your choice, but you would get a bed in a hospital bed somewhere if you sort of met the criteria for requiring hospitalization. So things were a little better organized this time in the second wave than in the first wave. In the first wave, it was, people are running helter-skelter. So, but this time, even the number of cases was 20-fold. The the organization was better. And I think at least in Mumbai, we coped to a reasonable extent, much better than the second wave, and probably a little better than some other parts of the country.
Right, thanks. Yeah, I've been also reading that Mumbai was faring better than other parts of the country. So if I zoom out to the whole of India, and some of us in the Asian Critical Care Clinical Trials Group, we looked at the bed capacities, the ICU bed capacities in the region, and we published this paper in Critical Care Medicine in the year 2020. And looking at India, it was estimated that in the year 2017, that's way pre-COVID, right? There were 29,997 ICU beds. That works out to be 2.3 beds per 100,000 population. Not super low, but also not super high. A little bit on the low side. And then we know that the second wave really hit hard. Perhaps worse, as you said, in other areas beyond Mumbai. So could you give us a sense of how badly hit in general the ICUs beyond Mumbai were in India?
Yeah, so I think in many parts of the private hospital, as you know, in intensive care beds in our country are largely in the private sector. Of course, we've got these public hospitals, but we've got many more beds in the private sector than the public sector. Again, like, you must have had that experience when you did the ABC study, that the statistics are not very accurate and it's difficult to get very precise information, unlike in many other health systems where, you can at a click of a button, how many beds are available in the private sector, public sector, ICU, non-ICU, and so on. So, yes, so there was a shortage of ICU beds. And, in this pandemic during the surge, there was at some stage, in the first stage, the authorities made it mandatory for everyone to be hospitalized. So even patients with mild, because we didn't know what we were dealing with, I don't think anyone knew what we were dealing with. So everyone had to go to a hospital. So there was a shortage of beds simply because everyone had to go to a hospital. And once the concept of home isolation and staying at home and monitoring patients at home came in, we thought that, we would have more beds available for the sicker patients. And when we came to the sick patients, I think initially we failed to categorize or distinguish between oxygen requirement and intensive care beds. So almost anyone who was breathless sort of got shifted to an ICU. And then we sort of realized that, you could manage a lot of patients on the wards just with a bit of oxygen, and you could reserve the ICU for the really sick ones who need either invasive or non-invasive ventilation or organ support or something like that. Unfortunately, during the second wave, a lot of patients were managed at home, a lot of patients were managed on the wards, but the load was so much, that it was just physically impossible to expand beyond a point. And I think one of the messages I would sort of suggest to everyone is that, see, for example, at the peak of the first wave, right, we had less than 100,000 cases per day. Right? The highest number per day was 97,000. At the height of the second wave, it was 400,000. So any government or any health system, how much would they plan for? Of doubling the capacity, tripling the capacity, 5 times the capacity. But when you go to 10, 15, 20 times the established capacity, any health system would collapse or would struggle. So I think public health measures are extremely important. So masking, social distancing, vaccination. I think every society, every country needs to really get that in place, and then you can reduce the stress on your healthcare system. So our healthcare system was stressed just because there was a huge surge. And I think we'd let down our guard at a certain point in time. We thought sort of things were getting better. It was almost coming to an end, and you could get back to life as usual and reduce your number of ICU beds, reduce the number of hospital beds. And we did not have that nimbleness or even the capacity to suddenly accommodate 10 times or 20 times the number of patients. So I think all over the country, people suffered, and especially in the northern parts of the country, there was a bigger problem. I think the variants hit there first, and then so I think multiple factors, and that really hit the ICU capacity in in many parts of the country.
Yeah, the Delta variant is brutal, right? I mean, many of us watched the news images of people walking around trying to get themselves into some kind of healthcare facility, and then after getting there, trying to look for oxygen. I saw images of family members jumping on to do CPR for some of the recently deceased loved ones. It's really harrowing. Was there some kind of triage mechanism? And if so, was it more arbitrary on the fly, or it was widespread and quite official and purposeful?
Jason, I can say for Mumbai, right, there was a triage mechanism because, like I mentioned, all admissions were centralized through a dashboard. So any patient who had to go to who wanted hospital admission would have to ring up a hotline, and there they would ask, what symptoms do you have? What is your oxygen saturation? And if the person there felt that person needed hospital, he would allocate him to either to a hospital bed, an oxygen bed, or an ICU bed. So there was some triaging there, and therefore there was not as much panic in Mumbai. In certain parts of the country, there were lots of patients, and I guess this triaging mechanism at a centralized level was not there. It was left to the hospitals to triage, and when you've got and when many patients come to a private hospital, it's became like a first come first served basis, and then the VIPs would get admitted to a hospital and they would block a bed, and if those sort of things happen, then the reserving patients fall back in the queue, and I guess that happened to a certain extent. And I think the other thing is, oxygen shortage, which was very much in the news, and Singapore helped quite a lot because we got a lot of help from oxygen tanks, which came from Singapore and many other countries, France and so on. So that helped. But oxygen is not just a medical problem. I think oxygen is a logistic problem. It's transportation, supply, and manufacturing. So, these are the things which are well beyond the ambit of medical staff. And it really needs a concerted effort, starting from manufacturing oxygen right down to transport and distribution of oxygen. So, the capacity of oxygen almost went up 10 times, the requirement for oxygen. And I think we were able to meet that capacity by, diverting industrial oxygen. And I didn't realize there was so much industrial oxygen in the country till all this happened. And, so the industrial plants, the steel plants and all those plants were, who used to make industrial oxygen, they made medical grade oxygen. The real problem came in transport, because these big, huge liquid tanks were initially those large capacity tanks. We put on a truck, oxygen tanker, but that could move very slowly, because of regulatory norms and because it's a dangerous substance and so on. And it would take a huge amount of time to transport from one place to the other. The steel plant or the oxygen production plant would be in another state, thousands of kilometers away. So and secondly, within the city, for that tanker to go and fill up the tanks at various hospitals, again, it would be a painfully slow process. I think at least in Mumbai and then in other parts of the country, we made smaller tanks. So transporting was done in smaller tanks so that they could move around in multiple trucks all over the city and fill up the oxygen in various hospitals. We also had these trains, so long distance trains. So you put an empty cylinder or empty tank on that, and the trains could go much faster with the tanks on. And then only the last mile or last few miles would be in a truck, in an oxygen tanker. So with the trains and trucks, we were able to double or triple the speed of oxygen delivery. So all those sort of solutions came in, but they came in once the crisis struck. So those plans, had they been there earlier, we would probably have responded much faster and much better. But we learned our lessons and sort of on our feet, so to speak. And we were sort of able to eventually solve the problem. But yes, there was a period of a week or 2 weeks where things were not looking good at all. So we were able to increase our capacity 10 times. Eventually were able to solve the transport and logistic problems and distribution to hospitals. And then, of course, within the hospital, plug your leaks, use as little oxygen as so on and so on and so forth. So it was a huge learning experience, of course, at a terrible cost. But hopefully, we've learned our lessons and it won't happen in the future.
Wow, who would have thought that I'll be listening to you talking about transport of oxygen, right? I mean,
Yeah,
it's just wow.
Something you never think of when you're doing intensive care, and even being in an administrative sort of role at some level. But this is way beyond what you can do as a doctor. This is, you require massive government transport, logistic. It's a huge effort.
Wow. So talking about what we can do as doctors, how about medical care? Were steroids widely used? Too little, too much? About tocilizumab, things like that? Or was there even ECMO, the usual medical care?
So I think you've hit a very raw nerve here. And I think one of the problems that we had was just overuse of all sorts of medication, including steroids, very early on. So, it was not unusual for the moment a patient is diagnosed with COVID, you have the positive RT-PCR or positive antigen test report, that patients would get ivermectin, doxycycline, azithromycin, fortunately not hydroxychloroquine anymore, but in the first wave that as well. So to get 4 or 5 of these so-called antivirals, then they would get steroids, and they would get oral steroids right from the beginning. And in many sort of, I'm not saying everywhere, but a number of prescriptions we've seen where we've had steroids of 16 milligrams of, of steroids, of dexamethasone or Medrol or something like that coming up. So I think, plus of course, all sorts of vitamins to boost immunity and all those sort of things. So I think there has been an overuse of medication steroids, and maybe that contributed to the early severity of illness in some patients at least. Tocilizumab was fortunately not used much because, in the beginning there was not much evidence on tocilizumab, plus it was expensive, but it became out of stock pretty soon. So, because again, when you have, even if you've got not using it you're using it only a small proportion of patients, the number of patients is so huge that you sort of end up using a lot of tocilizumab overall. So tocilizumab was not as much, but steroids were heavily used. And I think people tried all sorts of steroid combinations, apart from the conventional 6 milligrams dexamethasone. Then people were giving pulse steroids in certain situations. Patients were getting long-term steroids as well, because, we started seeing patients remaining breathless and having CT scan changes well beyond 1 week, 2 weeks, 3 weeks, so maybe they got prolonged doses of steroids, pulse steroids, a lot of things were tried. And, the other thing is, when you suddenly get, say, hundreds of patients coming to your ICU over in a short span of time, and a lot of them are hypoxic and a lot of them are not doing well on oxygen, I think intensivists and doctors and physicians felt compelled to do something. And we were actually clutching at straws. So if you read something in a journal, a case report, so there was this case report of 16 cases of bevacizumab in Chile, in China, and Italy. And so people are trying bevacizumab, people are trying methylene blue, so many sort of trials, experimental, non-standard medications were given, not in a setting of any trial or of an observational study. They were just given because people are desperate. So tocilizumab went out of stock, then people tried other sort of interleukin inhibitors, bevacizumab. So many drugs were tried out and all sorts of combinations were given. But I think at the end of the day, I think once the panic subsided, I think it was the basics of intensive care that everyone sort of fell back on eventually. But I think one of the things was that there was not panic, but there was a desperation to do something. You had patients dying in front of you, not doing well on ventilators. So everyone was looking for a magic bullet, which obviously was not there, but people were looking for that. So yes, a lot of drugs were used. And
you mentioned panic. I'm guessing, correct me if I'm wrong, that some of the panic, the fear is also for yourself, for the healthcare workers themselves or their teammates, how did this whole thing affect the mental health of your colleagues or colleagues in other states, or yourself personally? How did it feel? How did you guys cope?
I think working in a hospital and working in a situation like this actually brings the team spirit, actually picks up quite a lot in times of a crisis. And in our hospital, for example, amongst the medical staff, we didn't really have to give pep talks to people and say, look, we got to do this. In the first wave, when the pandemic had just struck, there was a lot of talking to be done, because you had to reassure people that, look, this is it, but we can be safe, we can be protected. And when people saw that we were still working and doing everything, sort of everything then just fell in place. But once you overcome that initial panic, and it was a fear of the unknown, more than, like, it would not only affect you, but it could affect your family. People had small children at home, your elderly people at home. So there was a fear for everyone. But once that panic and once the knowledge sort of came in and we had adequate personal protective equipment, I think almost everywhere, people rose to the occasion. I mean, there's no question about that. At least the medical, nursing, and paramedical staff in all the hospitals. And I think it's one of the most amazing sort of things is that in times of a crisis, everyone comes together. And we didn't have people shirking work. We didn't have people bunking work. We didn't have people taking leaves, and except when they were sick or whatever it may be. And because we were occupied and we were in hospital and we were doing things, I think more or less mental health was okay. We had to worry about people who were in quarantine because, they were, or people who were sick and in isolation. So that was a time when people needed support because, you could be isolated for 2 weeks, 3 weeks or so on. And people would come and see you. And at the most, there would be an occasional phone call or a video call. But I think there is an inbuilt resilience, and at least amongst the medical, nursing, and paramedical staff working in the hospital, they sort of knew what they were dealing with, and it was just a matter of time. There was support, of course, virtually, like we are virtually meeting each other now, but it was probably enough to just keep them going. And the real problem was sometimes overwork. And that contributed to a bit of the stress because when people were sick, they'd have to fill in extra shifts and extra duties for others and so on. But again, I think it's remarkable how resilient we were. And with whatever support we could give each other, I mean, we didn't have professional support, which was being given, though our hospital and many other hospitals had made arrangements, for counseling, for professional counseling remotely and so on. But with all that, I think we were able to cope reasonably well. And I think at such times, the team does come together. And even members who are not regular members of your team, they come together with you. So I think that's been one of the plus points, if you may call it, of working in this pandemic.
Wow, yeah, that's nice to hear. Do you feel that things are better? I just checked the WHO website. Even accounting for undercounting in the last 24 hours, 422 deaths. That's way lower than what we saw in the peak. Do you feel things are better? Just how things feel right now, and also the coordination across agencies, across states, etc.
Yeah, things have improved considerably, right? So, for example, in this peak, we'd seen about 400,000 deaths. We are, as of yesterday, we are down to 30,000 cases. So, I mean, 400,000 cases at the peak. We are now down to 30,000 cases, which is still a lot because at the end of the first wave, we were down to under 10,000 cases. But so we are still 3-4 times more than that. But we are more than 10 times below our peak. So things are getting good. Mumbai is also getting better. So yesterday we had under 300 new patients. which is a lot, but it's still much better than having 1,500 new patients every day. So, but it's a bit patchy. In some parts of the country, we're actually seeing cases rising. For example, in some of the southern states and some of the northeastern and one or two northern states, we are seeing the cases increasing. So we are just keeping our fingers crossed, and sort of there is prediction of a third wave which is going to hit us. So now no one is letting their guards down. Slowly, I think we are breathing a bit more easy now. I think life is restrictions and have also been lifted in part, not completely. So life is not back to normal at all. Vaccinations are picking up. We vaccinated a lot of people. We have 47 million, 470 million people have been vaccinated, but that's still, as a proportion of the population, it's still very low, less than 8%. But, and that's the problem we have to deal with, because we've got a huge population. So even if we've vaccinated more people than the US or the UK, it's still not going to be enough. So we have a long way to go, but it's progressing. So we are keeping our fingers crossed. We're sort of watching with bated breath as to what happens in the next few weeks, because there is a prediction of a third wave. While it's coming down in some parts, the numbers are going up in other parts, but we'll see. So things are better. We are better organized. And I think if we've learned our lessons from the second wave, I think we'll be able to tackle the third wave with, I can't say no one will die and more people, but hopefully there'll be fewer deaths and we'll cope much better, and let's keep our fingers crossed on that.
I think it's going to be an impossible question to answer, but I'll answer it and I'll ask it anyway. How do you see things panning out for India?
I think eventually India and maybe even the rest of the world will have to learn to live with this disease. And if we can get, and again, this may be wishful thinking, but if we get effective vaccines, maybe even if you have to vaccinate every year, if we can keep the mortality low, and just let it remain like maybe a bad flu, I guess we'll have to learn to live with that in future. And if we get a drug treatment, for the disease, like something we can pop a pill and get rid of the virus or whatever. I mean, nothing like it. And, I'm sure there is research. I know the US and the UK have got a big sort of program to develop for drug development and that kind of thing. So we'll see. But I guess we are going to have to learn to live with this. Variants will come, and hopefully, let's put it this way. A virus which is more deadly is not good for the virus in evolutionary terms. So even if it is more infectious, which is good for the virus, but as long as it's less deadly, we'll have to learn to live with an infectious but a less deadly virus. And if we get a good vaccine and we get a good drug, I think we can sort of get back on track. India has to have a problem in the sense of the population, density of the population in many parts. We have to have the discipline that many of the Asian countries have. We need to get that discipline into our society, as far as masking and following the norms and regulations and so on. And I think the second wave has put the fear of God in many of us, So like many people say that India is not is a God-fearing country. So you have to fear God, and the fear of God has been put in. And I think this will hopefully lead to better adherence to standard norms of social behavior, COVID-appropriate behavior, and so on. And I think we'll get by. But we've learned our lessons and the hard way, but it's good that we've learned them, and it'll stand us in good stead in the future.
Yeah, one final question. Since you talk about lessons, just to be specific, this recording is made on the 3rd of August 2021, and according to the WHO website, many different countries in Asia, Southeast Asia, are going through a terrible wave as a result of Delta, right? It's almost as if we are just lagging behind India by a little bit. Indonesia, 22,000 cases daily. Thailand, Malaysia, 17,000 cases daily. The Philippines, 8,000. And all these are numbers, but similar stories of what India went through: hospitals overflowing, ICUs unable to accept, people just dying, and no places to bury them, etc. So since we talked about lessons, as someone who maybe has been there, done that, I'm not sure whether that's the right phrase to use, or is still going through it and will continue to go through it, any advice for intensivists in the region or maybe worldwide who are still battling this or who are preparing because the wave hasn't hit them and they are quite certain that it will hit them? Any last words of advice?
I'm not sure I can advise anyone, but I think, Singapore, Hong Kong have done well, not because you had the experience from SARS and MERS and so on, and this was the first time that we missed SARS and we missed MERS and we missed those sort of outbreaks, but so we did not have an opportunity to learn, and we've sort of really been hit by this huge pandemic. So if you ask me what I have learned from this, or what has struck me about this whole pandemic, is I think the first thing is, we have to look after ourselves and we have to look after our colleagues and staff. Because if we don't do that, we can't look after our patients. And I think it's extremely important to look after staff, especially non-medical staff and even medical staff, the juniors. And in this sort of battle, if you may call it that, the juniors staff, the young doctors have been, magnificent, because they've been at the front line doing all the work and extra shifts and so on. So you have to look after them, because if you don't promise to look after them when they fall sick or their family members, they're not going to be motivated enough to work for you. So if you want to motivate your staff, you have to tell them that, look, we will take care of you in our ICU, in our hospital, or we will make arrangements for you and your immediate family if it comes to that. So, and we've done that in our hospital, and many hospitals have done that. So we have to do that. The second thing I've learned is that a pandemic like this, or a major outbreak, is not just a medical disease. It is a socio-economic and political problem. And, it causes a lot of economic disruption, a lot of social disruption, mental health problems. Children don't go to schools. They've not been to school for a year and a half. They don't know what is it like to meet other children, and what it is to play in a group. And, so I don't know how that's going to affect their social development and, the social skills and that kind of thing. Lockdowns and so on, they just disrupt society like it's unbelievable. So that's something we have to deal with. You have to deal with the aftermath, the psychological and the mental disease aftermath of that. We'll find out in due course. Thirdly, of course, we have to build capacity to tackle infectious diseases, because there might be a new virus or some other thing coming along. But I think equally, our hospitals or the healthcare system must be able to also provide services for people who have other diseases. We've been so focused on treating COVID and converting capacity in our hospitals for COVID-19 patients. The patients who need other sort of services like cancer patients, heart failure, diabetes, dialysis, they've lost out. And I suspect there's a significant collateral damage on that front. I think we have to make sure that we, of course, look after the COVID-19 and pandemic patients, but we also need to provide for other patients who need continual and ongoing care. And I think the last thing is, when it comes to actually managing patients in ICUs, I think stick to the basics, like good old intensive care. Nothing like that works. Stick to the principles, infection control, prevention control. Of course, take your personal protective equipment, but do all the things that we've learned, say 5 years back, or even 2 years back. Do them well. Don't wait for magic bullets. If a magic bullet comes, well and good, but I don't think as of now we are looking at any magic bullet. But stick to the basics and do your simple stuff. Do it well, and keep your fingers crossed. I guess that would be the bottom line as far as ICU management is concerned. And you just pray that your government, your society, and all gets together. And like we talked about oxygen, it is not just a medical issue. It's a huge problems spanning across specialities and administrative departments and that sort of thing. So the whole country needs to get their act together to tackle something like this.
So, Jigi and Dr. Divatia, I just want to thank you for the very wise words and also the inspiring encouragement that you have provided us. It's not often that we get to speak to someone who's been through such a bad wave. I hope that it is never going to be too often. But the opportunity to hear from you, I'm sure to many people in the region, maybe in the world, will be very much welcome. So thank you again for spending the time with us here. Thank you, Jigi. Yeah.
Thank you, Jason.
Yeah, thank you. To everyone else, everyone out there who's listening to this podcast will be made available as widely as possible on different platforms like YouTube, like Spotify, etc. Please feel free to share it with your colleagues, your friends, anyone who's interested in anything related to respiratory care or intensive care or COVID-19. We'll see you again in future podcasts. Thank you very much. And thanks, Jigi, once again. Thanks.
Thank you.